We are live.
Good evening, friends, from the Indian Society of Critical Care Medicine, from intensive care doctors, anesthesia doctors, physicians who work in ICU. I think today's webinar actually is focusing to attract attention for all of you in this subject of brain death, donation after cardiac death, and the way forward. And I've got a very, very good panel on the board. And the discussion which we are going to basically go through before I introduce the panel is going to be about two major papers which the Indian Society of Critical Care Medicine brought out as joint papers in the last couple of months. One of them was a joint statement about donation after cardiac death with number of societies: the Indian Society of Critical Care Medicine, the Indian Society of Organ Transplant, the Renal Society, the Liver Society, and that was a consensus statement that DCD can be done in India and how it should be done. And the second one was spearheaded by Dr. Kapil Zirpe, which talked about how to sort of have our donor criteria extended. Why are we rejecting donors? And all of this boils down to one pertinent question: that why is our country divided in terms of the number of donations happening as we go from the north to the south of our country? There is a very clear divide as we come towards Gujarat, Maharashtra. Below Gujarat and Maharashtra, people seem to have a very good acceptance. Doctors seem to have a very good acceptance. Or is it something else? And as we go across that, so across the Vindhyas on the north side, you seem to have the same amount of patients, the same category of patients, but somehow the organ donations are not happening. So I'm going to take this opportunity to introduce my panel. I have got Professor Rajkumar Mani, who is ex-president of the Indian Society of Critical Care Medicine. He has been spearheading the campaign for quality of life, end of life, and brain death on organ donation for the India as well as for the Indian Society of Critical Care Medicine. And we look up to him for any legal matters, any problem any one of us has in the society. He's always a phone call away, and we are very, very happy to have him on the panel today. The next person I have is Professor Prasanna Bidkar. Professor Prasanna Bidkar is the neuroanesthesiology head and division head at JIPMER, which is a premium institute which looks after a variety of patients. And to have somebody with a specific neuroanesthesia experience, which sort of deals with these brain death patients in and out, patients who have got severe brain injury in and out, is going to add on a lot of value to the webinar today. The third person I have is Dr. Kapil Zirpe. Dr. Zirpe, again, is a consultant intensivist at Pune, but importantly, he is the one who has been spearheading in Pune as well as in Maharashtra along with me. We both of us are on the task force formulated by the government of Maharashtra to look after the organ donation as well as increasing the amount of awareness for organ donation. And he has been spearheading this in Pune as well as across the country again. And Dr. Chirpe has got a very keen interest. He heads the neurotrauma unit, so he's going to add a lot of value again to our discussion. And we've got Dr. Deepak Govil. Dr. Deepak Govil is the immediate past president of Indian Society of Critical Care Medicine, and he has been a avid supporter. He works in Medanta, the Medicity. He's got excellent, rapport with his patients. And one of the questions I'm very keen to ask him is that why is Medanta not picking up in terms of organ donation? So there is a trickle happening in Medanta, there's a trickle happening in Fortis in North, but it doesn't seem to sort of match up with the way Gujarat, Maharashtra, Tamil Nadu, Karnataka is going. So with this, I'm going to open up the panel. First question, we have I mean, it was not planned this way, but it does happen that we have a north and south divide right now. So I'm just going to spend first 5 or 10 minutes mulling on the point that why is north not picking up. So Professor Mani, I would like to ask you, with your background of, you always have been a proponent of end of life care, brain death. Why, sir, is the North struggling? And then I would leave the floor open to discussion between Prasanna, Kapil, and Deepak. You can take questions. I think we want this to be an informal discussion rather than me asking every question. Professor Manix, you can start first. So you're muted. So you're muted.
It's a very interesting question.
we have also wondered, what are we doing wrong, or what is the right thing we are not doing, that we are lagging so far behind our colleagues elsewhere in the West and in the South. So the one of the reasons I think is, of course, if we talk about the public awareness, there's not been such a vigorous public awareness campaign um, as in the South. It was spearheaded by Mohan Foundation for many years now in the South, and they played a very crucial role. And it is happening here, but it came a bit late. That's one thing. Number two is that, we are not motivated at the policy level to identify brain death and to activate the process of organ donation. Now, we have certain, in the world actually, our deceased donor organ donation is abysmally low as compared to the rest of the world. So it is comparatively better in the South as compared to the North. However, in the totality is very low. In Chennai, in Tamil Nadu, it's 1.4 per million. In the north, it is less than 0.5 per million. The rest of the world, it is in beyond 10. In the advanced countries. So this is crazy. Why are we really losing these opportunities? I think at the policy level, we have not recognized two things: that we cannot increase the organ pool unless we identify and mandate the declaration of brain death. Okay, that is the prerequisite. Before organ donation comes, you have to identify brain death. In our country, we seem to put the horse before the cart. Okay, we first talk organ donation, then we identify brain death. This is ridiculous. Brain death is a clinical diagnosis, so the clinical diagnosis must come first. Now, Kerala has taken the lead that you have to declare brain death. Whether or not it's a potential organ donor, you declare brain death first. And you continue with intensive care if there's a potential organ donor. And do not continue with any intensive care. You withdraw all intensive care if it is organ donation is declined. Now, third point is that there are certain logistics which we don't facilitate at the policy level. What are they? For example, a majority are MLC cases. Now, we have a problem that you have to have autopsy. We should not be in the way of the law to identify the cause of the cause of the trauma. Now, all this is facilitated in Tamil Nadu and elsewhere. You see that the process is expedited. The autopsy is done in the OT, and all the certification paperwork is done in the OT. So there is no delay. Wherever there is a delay, the family can change its mind. Family can see this as a process which isn't smooth. And so I think these are the reasons. They are all correctable reasons. And, we have certain problems in the TOA as well. We should not be needing a consent for apnea test. Okay? It's a medical test. Why should we need a consent for it? That is constraining. Only now it has got corrected that you don't have to be an organ retrieval center to be recognized for identifying brain death, and any ICU can be recognized by the AA. I'll stop here because many people are there who
Thank you.
Deepak can contribute a great deal why this divide is there.
Yeah. So I am going to go to Deepak for a quick comment, and then Prasanna, you can add on that what should the North do?
As Dr. Mani has rightly said, there is a awareness, no doubt about it. Even some attendants also are aware that organ donation is a good thing. They sometimes do ask. But in corporate hospital, what I feel, everything comes down to the apprehension by the consultants and the cost factor. Like in my unit, in my hospital, I have seen that once you tell attendant that now patient is brain dead, whether he or she is in purview of organ donation or not, attendant starts saying that why should we pay after this? So many times neither they are giving consent for organ donation nor they are ready to take patient, and then they start fighting with the administration that your doctor has already said that he or she is dead and now you are making bill, so you should stop. And that becomes a point where everybody is little scared to declare brain dead, because then the person becomes in a controversy. That is what my personal experience is. I don't know whether it's a right forum to discuss this or not.
No, it is.
No,
It is. Whatever is the
I
fact.
think it's very much a right forum to discuss this, no doubt about
Right.
that. Dr. Bidkar, for you and then Kapil.
Yeah, thank you, Dr. Rahul. So, as Dr. Mani pointed out rightly, he has a lot of idea about South India, and the Mani is a South Indian name. I think sir is from South India. So, there are several levels where there is a lot of improvement in the South as compared to the North. One of the main reasons for this better outcomes or the organ retrievals is because of the overall health infrastructure. The basic health infrastructure, primary health care, secondary health care is very well developed, particularly in Tamil Nadu, Kerala, and Karnataka and Maharashtra. That is one of the reasons that it has picked up. If you see the best of the centers which are doing a cardiac, liver, or kidney, that's the highest numbers are from Tamil Nadu. There is no doubt in that. Basically, the reasons behind that is one is the public awareness, because lot of the public figures like cinema personalities or the politicians underwent organ transplants somewhere in their lifetime here, and lot of the movies have been done based on the organ transplant, plus the presence of the Mohan Foundation and the organ sharing network. One of the best organ sharing networks you will find in India is in Tamil Nadu and Pondicherry. So that's one. See, from the hospital point of view, everything is taken care of for the patients, for their betterment, for the person who was going to consent for the organ donation. First of all, the relatives themselves are aware of the organ donation most of the time. There are transplant coordinators in every hospital here which do a proper counseling, and then the administrative level, like if they want particular time of death also, we try to accommodate that also into the considerations here. And also, when we do the organ retrieval in the OT after the brain death declaration, the autopsy is carried out in the OT itself. All the paperwork are done in the OT, and the patient body is handed over to the relatives. Along with the institute ambulance, it will be handed over to the relatives, and one of the representative from the hospital goes till the crematorium till all the functions are done. That's the individual level. Even the hospital takes care a lot of things here. Then the third is that the administrative level, the state government, if you see the Tamil Nadu state government and the Pondicherry state government, there is an excellent support from the, even if some issue arises, a medical or a legal issue or an ethical issue, they are always there to help the every cadre. The organ this sharing network, Transtan, everything a proper record is maintained where the heart will go, where the liver will go, particularly lungs and heart. Even we have not started in JIPMER, we are there in the liver, kidney, cornea. So even these organs are not wasted here. We immediately call the Chennai people. They, from there the list is decided, that in that institute comes into here, assesses, and they take the organ, and a green corridor is formed immediately. Then the other issue is of when we declare the second declaration and time the death, there are a lot of legal procedures to be done by the police, since most of these cases, understandably, are of medical legal importance. And Pondicherry being a separate union territory, most of our patients come from Tamil Nadu. The Tamil Nadu police has to come here. So we had some issues when we met the Tamil Nadu chief minister. It has been blandly told that if they do not attend, please call me. We will take care of it. That is the amount of support we have in South India. That is why, even if you see in the state of Kerala, it started too very late, maybe around 2012-14. Kerala started doing this all organ declaration and transplants, and there were some issues. Now it is the first state to come up with say that if you declare brain death, you can discontinue the ventilator also, which is a always dilemma for all the us intensivists, that whether to discontinue ventilator or not, whether it is legally permissible. Kerala came with the rules. There were some issues with organ sharing. Kerala called all the stakeholders and decided. In similar lines, Karnataka also has picked up, because of the main is the administrative and the social awareness. Over to you, Rahul.
Thank you, Prasanna. I think you brought out very important points. So similar things have been done in Maharashtra. I want to have Kapil to sort of highlight how we have been doing in Maharashtra, and then, of course, he has a very wide experience, so he can give a little overarching thoughts about this, and then we go back to our paper discussions.
Yeah. Good evening to all, and thanks everyone for sharing. First thing, let's don't be the feel-good factor. Whatever the South and Maharashtra are doing, it should not be the feel-good factor because we are way behind what we are expected. 0.65 per million or 7 per million is not the rate we are anticipating and expecting from the India after the 25 years of the our THOA Act. So please, first thing, we should come out of that aura or feel good factor, or please each and everyone that we are doing good, somebody is not doing good. That I don't agree with that. We are not doing good, we are not doing as per the expectation. Now coming back to the Maharashtra and Western, if you see the first cadaver organ donation happens in Mumbai on the 7th of April 1997, followed by Pune 11th of April 1997. So the long back the Maharashtra started this particular organ donation concept and the era, and they started following that very meticulously. Now in 2022, there is no monopoly of the, sorry to word use this word, of the metropolitan cities like Pune, Mumbai. Now Sangli, Kolhapur, Solapur, Latur, Aurangabad, Nagar, everyone is activated, only one is aware about the organ donation concept, and they are active in doing the organ donation. So sometimes what happens, there are less in Pune and might be in Solapur and Kolhapur, they are doing regularly, and that is the beauty and success of this organ donation activity. And I always give this credit to the, not only to the doctors, not only to the this thing government agency, it is those thankless job doing workers like a JTCC in regional areas. They are continuously 24 hours, they are following the list, organ sharing, communicating. I think they are the major heroes as compared to the what doctors we are doing in the ICU. So this is one of the reason Maharashtra is doing well, and we are following the South model. What Dr. Bidkar says, the South is one step ahead of the nation, I will say, rather than Maharashtra. Or their legal system is very cooperative, their infrastructure is good. We are also matching that infrastructure now, and that's why the Maharashtra is picking up. So it is not only one point. Like Mani said, the print media has to support, and that's what started happening in Maharashtra since 2012. Print media is absolute in support promoting the organ donation. Second thing, the healthcare system need to be penetrate and reach out to the remote areas. That is what happening nowadays in the Maharashtra and West region. That's why the reason. Third thing, the local JTCC as well as the SOTO and ROTO, their coordination is much better as compared to the previous years. That is happening in that. And the fourth thing is the concept of the potential donor is developing. That is might we will discuss during that paper discussion. But overall, every agencies, everyone need to do it their what are the work, and it will move. But we are way behind. We should discuss how we can reach to the 10 per million rather than 0.6 and 0.7. I think that summarizes the what Rahul would like to know, why we are doing little bit better, not the better, little bit better as compared to the rest of the ones.
I think it's a very nicely put up by all four of you. What I feel is that the problems which are there are easily correctable. We don't need to reinvent the wheel. We just need to adopt each other's practices, good practices, and go on with the program, because the program will be successful. They have no doubts in my mind, and it's just a matter of time before it will start picking up in North. With that, I'm going to bring up Dr. Zirpe. Dr. Zirpe, you sort of spearheaded a paper on organ donation, which was published recently in the Indian Journal of Critical Care Medicine. I would like you to talk about that, and then I would like you to sort of spearhead the discussion around that with all the panelists. You can consider me as a panelist for this, and we could take up the very important issues which you brought out in that paper.
Yeah, Rahul, thanks. Regarding that publication recently in Indian Journal of Medicine, we have come up with the position statement on behalf of the Indian Society of Critical Care Medicine. The evaluation and select of donor. Now let's start taking our own responsibilities. Let's start following what we are doing. There are two ways. One way is the social media awareness and various activity to promote the families to go for the consenting. That is really in everyone's hands, but it's very difficult, in particularly nowadays. Come back to the our own responsibility. I was just my thought process is why we are not picking up probably whichever the available donors, whether we are justifying that. So I always discuss in every platform what is our conversion rate. What is mean by conversion rate? Suppose I have 100 donors, so how much out of those 100 branded donors we able to convert into the consented donors? Out of that consented donor, how much we able to convert into the real time donors? Out of that real time donors, how many organs we able to retrieve? So it's a chain of the events. So suppose 100 donors consented 50. Out of that, organ donation happen around about 70 organs. So probably we are losing a lot more rather than only concentrating on the promotion activity and the print media. So that's why this thought process leads to the come up with this position statement. So where is the issues? If suppose I am an intensivist, I am daily taking round, I am in a position to pick up those severely brain injury. So where are the issues? The first issue what I came across is the just identifying that potential donors during the rounds. We probably giving yes, we need to give our first preference to save the life, but simultaneously on the back of the mind, every intensivist should have a concept of the potential donor in an acutely severe brain injury patient. Second thing, if you have picked up the acutely potential brain donor, we need to concentrate on the maintenance of that donor. What happens? The identifying the potential donor and the consenting happen. This gap might be 6 hours to 6 days, and when the after 3 days, 6 days consent happen, donor should not be crashed. So that is a second gap in the process. Third one is we are probably just ruling out the marginal donors during the rounds. Like he's on 3 inotropes, he's not a good donor. His age is 75, he's not a good donor. He has the comorbidities like he's a CV and this, he's not a good donor. So probably we are ourselves are not able to justifying those marginal donors. And the fourth thing is what about expanding criteria? Okay, I have a 75-year-old male patient with the diabetes and hypertension, but he's perfectly mentioned, can I fit it into the some organ rather than just saying no and wasting? Again, the wasting is not right word, but I want to use that word, wasting the three organs. Shall I give a second thought that can I go ahead with the considering him as a potential donor? And the fifth thing, the most important thing, when you are taking round, there is a nurse, there is a junior doctor, there is a coordinator, everybody is moves around with your thought process. They need to take into the account, they need to take into the conference. Yes, this is the where we should start discussing during the round. So intensivist led team are the right in position to take that responsibility, recognize and convey that message into the unit that yes, everyone need to be take the responsibility. So these are the some gaps I have recognized, and on that background we have prepared this publication. It is worth reading. I request everyone to just read it because it's a one document at a one site where you can get the answers of the every questions we are day to day facing. That's what the purpose of this paper. Rahul, over to you.
Excellent. I think you sort of said it right. The last words where shouldering the responsibility comes up very important. I'm going to ask Dr. Bidkar and then maybe Dr. Deepak can highlight or Dr. Mani can highlight. Have you been sort of using these marginal donors? And if so, yes, how are you sort of optimizing them? And if no, then why are we not sort of considering them? Dr. Bidkar.
So, to tell you frankly, we are very skeptical about this. We are aware of these extended criteria and the marginal donors. We try to accommodate them as much as possible, but we are skeptical about also of using them, particularly in our institute, because ours is a totally free institute where not even a single rupee is charged to the patient. So when we want to take something and invest so much, like for example, even for a liver transplant, we are not charging, I think, more than 2 lakhs or 3 lakhs for the patient. That's it, what we are charging. So when it is sort of that, we want to make sure that the organ is entirely feasible and very well maintained. we have a good intensive care team, and we try to sort of see them and follow them for a period before we go for a first test of declaration. When everything is all right, we feel, and majority of the organs can be retrieved. That is the where we decide. For kidney, we are quite liberal now. We have been using the extended criteria, and many of our donors have been 65, 70 years also. So we have been using. For others, we are little bit skeptical whether to do it or not. However, we did for liver transplantation also. We have started on that. Having said that, I feel we have to go for it. There is no other option because the demand is much higher than
Yeah.
the what the supply is. So we have to look into every aspect of going for whether the recipient is fit for organ donation, and we have to go for it.
So, Dr. Bidkar, I think there were two parts in your answer. You were wearing two hats. One hat was the receiving intensivist, whether you want to have a marginal liver or kidney or not. But if there is a patient in your unit who is borderline, would you not optimize him and make sure that even if he's borderline, he goes ahead with the brain dead declaration and organ donation as a process? And then the receiving team may or may not choose an organ. That's a different aspect, because that's a different discussion that needs to be educated to the liver guys, to the kidney guys. But from ICU point of view, I thought that would be an important thing to do. Dr. Mani sir, and then Deepak, your thoughts on this extended criteria donors. Sir, again, you're muted, sir. Mani sir, you're muted.
I don't have much experience with extended criteria. But what I do think is that our lungs are getting, most of the lungs are not retrievable. So, that has become a problem because we've almost always we are catching the low hanging fruit of kidney, okay, and occasionally liver. But harvesting the lung has not been a culture. Okay, we are not careful with the maintenance of the organ donor, with the maintenance of the lungs. So I would like to highlight that, extended criteria have to be tested, whether how successful they are, what is the degree of graft rejection or delayed graft functioning. So we don't have that for most centers of our country. Okay. It depends on the experience of the individual centers. Receiving centers, how well they use these criteria. At least where the cancer thing is concerned, I think those cancers primarily in the brain, confined to the brain, we are not rejecting them outright. Okay, so we go ahead with that. And in fact, even some of the chronic infections also, I think we are no longer that strict. Okay, so having said that, we must focus now. See, last year more than 100 lung transplantations have been done, in a majority, mostly in the south. So lung transplant is here to stay. There are many patients asking for feasibility of lung transplantation. So we must keep that in mind and increase the pool of available lungs by careful, ventilation of potential donors.
Deepak, your thoughts on this?
Look, if we see the international trend, every country is moving towards the extended criteria. And looking at the deficiency on the numbers of the organ or the available organ, then there is no other way around. We can't ignore these extended criteria. But certainly in North India, the normal donation has not picked up. So talking about extended criteria is little difficult. But as Dr. Mani sir has rightly said, that now there is a renewed awareness about the organ donation and this whole transplant program because of the corona. It has got two aspects. In the corona, people got aware that there is a lung transplant type thing which can save the life. And side by side, the corona, many centers, the transplant program took a very back seat, and the numbers has gone down drastically because majority of the donors, whether they are healthy or unhealthy, not unhealthy, whether they are healthy, but if they are turning out positive, then the transplantation couldn't be done. So that is the current situation.
So, as sitting on the moderator's chair, I might take the liberty to actually say that for North India, the way to actually go forward might be to look at marginal donors, which might be the low hanging fruits for you guys. So elderly people, people who have been in the hospital for a long time, who are now brain dead and have got 2 or 3 inotropes going on, you may be able to perhaps convince these families, and go ahead with donation by declaring these patients brain dead, which might be then the way to sort of show to the people who are relatively young, who are road traffic accident patients, who have multiple organs which are completely preserved, but unfortunately just brain with a low injury. So that's my interpretation. Maybe I am wrong, but that might be the way to look at. Kapil, your thoughts on this, and then we are going to move across to the next paper.
Exactly, you are hit on the nail. In fact, Deepak, if you again, the target is not the word, but if you think about such thing, I'll give you the one example. We have started in 1997. Up till 2012, we have done 25% of the whole organ donation number. That means something 120. From 2012 till 2020, we have reached to the 120. That means the almost 75%. Only two changes we done in our whole process. First thing, we started accepting the age more than 65, because our liver team was very aggressive and very competent and very cooperative. And second thing, you started using the expanded criteria. So what happened? Before 2012, our 98% of the donors were road traffic accident, and after the 2012, our 52% of the donors were CV, that means the stroke and IC bleeds. Look at the change. Now, what change is there? It is next to impossible to convince the young person's family. It is an unexpected death of that earning member, and to just convince them for the donation. This is happen all over world. Forget about India. All over world is moving towards the DCD, because there is just next to impossible is to take the consent, even though they are educated, even though they are doctors sometimes, even though they are well versed with the concept of the organ donor, their mindset is not in stage to accept that. And the moment you switch the game to the your age donor, like 65 or 70-year, my grandfather or grandma, if somebody says that would you like to consider the organ donation, yes, of course I will say yes, because the families are prepared, we are in condition, we know that we want to see our near dear one in someone's life. So that is how the expanded criteria donors may help to increase your number, and we are following. Believe me, our major now for donors are in that criteria rather than the RTS. And Dr. Bidkar says regarding marginal donor, there is a difference in between the extended and marginal. Extended donors means you are going certain extended criteria, but marginal donor is the intensive assessing. Suppose your donor is marginal, optimize him. That's why I said the last chain of the event is not only conversion, not only organ donation, the multi-retrieval. I always insist to my team is that I am not interested in a single organ retrieval. I am not interested in number. Okay, Rubiol did the 50 donor. I don't want 50 donation. I want 230 organs to be retrieved from that 50 donor. So that is marginal donor. Marginal donors are compromise, hypotension, multiple inotropic support, hypovolemic, infection. Let's put on all your expertise. If the healthcare system is this thing, put them on ECMO, put them on hypothermia, put them on higher antibiotic, your invasive monitoring, advanced hemodynamic monitoring, and that is where, see, I always say the one donor saves the 7 or 8 lives. So we are managing the 8 patients simultaneously. Then you have to justify your this thing. So this is how I look at this problem, rather than just seeing as organ donation.
Yeah, I think so true. So truly said that you are managing not one patient but 7 or 8 lives, and it is imperative that we put our best people on the job. We put our best thought process together, so that we are able to actually convert this into a multi-organ retrieval. I think that's a very important aspect. What very often happens is people are not putting their best person on the job. The junior most registrar is often asked to actually look after this patient, and yes, I mean that person cannot be blamed, because this organ donation is a very intricate process. It requires a senior consultant, an intensivist, to actually monitor this patient time and again and make sure that things are in the right direction. Rule of 100, which might sound simple, I'm not going to go into the details of that, but to maintain that rule of 100, you require a lot of expertise. Kapil, you want to share something? You put your hand up.
Just 30 seconds, just 30 seconds. When we say that we are managing the marginal donor or any donor, just put your best person, because he's dealing with the 8 teams. So he need that type of the understanding of the disease process and this thing. And he should not be the junior person, because otherwise he get irritated. Every team asks the different question and they are like a demands. We need the chest circumference, we need the height, we need the weight, we need the elliptics. That person needs to be cool, knowledgeable, put it on paper, give them the answer, write down, because you are working on 8 lives. Sorry, Rahul, you can continue.
No, I think you are right, because the liver team, the kidney team might want the CVP to be 10 if at all they insist on it. The lung team would say bring down the CVP to 2 because they want dry as possible. So it is a not only irritation, but it is also a challenge managing these patients as well as looking at the teams. So we've got 35 minutes into this, and I'm going to bring across to another aspect, and then we can come back to the expanded criteria donor. So we all have been very, very comfortable listening to tissue donation, eye donation, which have been happening in our country. Netradan is one of the most supported programs of Government of India, and big people like Aishwarya Rai and so many other names I could take, who have actually volunteered to be eye donors or cornea donors, what we call medically correctly cornea donors. And the program has got a lot of acceptance across the world. And, so has now skin donation been picked up as well. But the important aspect of these two donations is that it happens when the heart stops. It actually happens when the patient is declared death by the circulatory criteria. And across the world, I experienced it for the first time when in 2004, 2005, I became the organ donor coordinating doctor for my hospital, where Australia went through a big change in the way they looked at organ donation, and they introduced DCD as a program nationally. And donation after cardiac death or donation after circulatory death does not have that question mark about brain death at all. Brain death, where I mean, let's talk from a layman's perspective. I'm not talking from an intensivist perspective, but they still have these questions about heart is there, patient is warm, and all those things, which are completely taken away by DCD. And we had Dr. Mani, who has been sort of spearheading end of life care, and he spearheaded this program with me and Kapil as well, involved as well, and the rest of the societies, where we talked about donation after cardiac death. And donation after cardiac death seemed to be the way forward. There are already a couple of institutes in the country doing it. I would like Professor Mani to just sort of talk about this donation after cardiac death as a concept. How can it be done in a legal way? What does the laws talk about that? And then we will discuss amongst ourselves.
You see, conceptually, as Rahul has said, that you see, most people die in the circulatory way, and there's no ambiguity about circulatory death, isn't it? It's very clear. So if you have to expand the organ pool, if we ignore this group of deceased population, then we are going to be really the poor. Now, 17 countries in the world have a DCD program. I think the first DCD was done somewhere in the 90s, and many countries, in a few countries, it's a substantial proportion of the deceased organ donation. In the Netherlands, is actually more than 50% of deceased organ donation. So the pool has increased tremendously owing to the DCD. Now, another way to look at it is, people who are altruistic, okay, another function is not retrieval of organs, is another function. To give the altruistic expression of the patient or the families, give what do you call, arms and legs to the altruistic tendencies, okay, to make it count, make it express. I'll give you an example. You would have heard of the case of Venkatesh versus the state of Andhra. Okay, way back in, was it 2006? I think it was 2006. Now this was Venkatesh, who was a member of the Mohan Foundation, and he was an active participant in the promotion of donation awareness. He had Duchenne muscular dystrophy. He was now close to 30. Now it had run its course, and he knew his end was coming. And he landed up on a ventilator, and he requested that his organs be retrieved. Now it was declined. Okay, the doctors got shocked. I think the administration got shocked. They thought he was asking for euthanasia. Okay, we did not have a concept. We did not understand what he means by I want to donate. He's not brain dead. So the Andhra Pradesh government, Andhra Pradesh High Court declined it. His mother had campaigned. Mother was an activist. She campaigned. She was also an activist with the Mohan Foundation. She campaigned that her son's last wishes be honored. They declined it on the basis of saying we can only retrieve from heart-beating systems. Okay, our law doesn't allow retrieval from non-heart-beating persons. However, there is no such thing written actually in law. If you look at TOA equates the fact of dying, both neurologically brainstem and circulatory as the same. Okay, so they are equated. But what they have done is they've stopped short in creating an SOP and a protocol for DCD because they did not understand it beyond that. We have an opportunity now to create a policy because it's down the road now. It is how many years now? It is now
30 years.
Now, down the road, we are in a position. So many societies came together, as Rahul had pointed out, and we made a consensus. Now, what is the difference between DCD and determination of death by neurological criteria? The difference is you think of organ donation in somebody who is brain dead already. Okay? But in DCD, you have to anticipate. Okay? You have to anticipate. It's an anticipation. So you can talk to the patient directly. You can talk to the family directly. Or the patient can, obviously make it a part of the advance will. In most of the brain dead individuals, it's a trauma and all that, you don't really anticipate. So you don't generally leave an advance will. But people who die by DCD, majority are not in that young age group, and they are able to anticipate. So you have to have a discussion, okay, of withdrawal. So this is the crucial step. WLST of withdrawal of life support. Then after withdrawal of life support, you do not intervene. You allow natural death to take place, allowing a time for no spontaneous recovery of circulation. Okay, that is 5 minutes on average in the world, but it may vary from 2 minutes in the US to 20 minutes in Italy. So having a hands-off period, okay, and having had previously a discussion, the two processes should be separate. Okay, the WLST decision, that depending on the prognosis, depending on the medical opinion, depending on the patient's values and wishes, you have a shared decision-making process that is well described by the Indian Society of Critical Care Medicine and IAPC guideline of 2014, and even DNAR is now established by the ICMR publication of consensus publication, and it is supported by law constitutionally. We'll talk about it separately. So it's supported by law. So if you have a WLST process, have a hands-off period, logistically you discuss in a way that the ethical side, the emotional side of the family, all this is looked after, and you retrieve organs where a timely manner. So what happens is you can expand the pool of the organ, not only kidney and liver, but also the lungs and heart and pancreas and intestines. Okay, so all these are possible because it's a more planned. The control. What I'm talking about is controlled DCD. There are 5 types of DCD by Maastricht, depending upon the site and whether it's planned or unplanned. Okay, if it is in the ER, the patient brought dead or has a cardiac arrest immediately after bringing in, they are the first to master it. Okay. The third one is the controlled that I was talking about. The fourth one is after you're brain dead, while you're waiting for retrieval and all that, you have an arrest. You're already certified dead, so you don't have to go through any process. You can just retrieve all. And the fifth one done in the world is different. It is those people who have opted for euthanasia, they can do, but in our country, euthanasia itself is not allowed. So what I want to say is the process is required up to WLST, and the process is required after the decision to retrieve organs. They have to be separated. Okay, that uncoupling has to be there. And once the coordinator has come in and has broached the subject, and the family is willing or the patient is willing, then you can take up the matter forward in order to get many other consents, procedural consents, for perfusion and other things, okay, for organ improving organ viability. So those things can be taken in a systematic manner. This is feasible, and please look at this consensus document. And this is going to be submitted to the government, because I think the Mohan Foundation started with that premise, that they had talked to the government and they wanted a consensus document. So I think the crucial point here is the intensivists must believe that they have enough now to have proper end-of-life care decisions, which will include WLST. Have the confidence, okay, and not just go by lay opinion or by poorly informed opinion of saying no, this is illegal or can't be done and all that. And we have not done it before. See, if you have to break the glass ceiling, you do it only when others have not done it and you are doing it. Okay, so we have got to be champions. We've got to take the lead, and it's an intensivist focused process, this DCD, because the WLST decision is taken there. If there is, after the WLST, it takes too long for cardiac arrest to take place, the organs are not expected to be viable, then you go on the pathway of palliative care, okay, end-of-life care for that person.
Yes.
So this process is very crucial, WLST and the system of palliative care in the hospital, then we can expand the pool and be abreast of the times. That's very important. We are very much behind.
Dr. Deepak, you had to ask a question. Did you raise your hand?
No, I have not raised the hand.
Sorry. Okay, so I'm going to go to Dr. Professor Bidkar then. Professor Bidkar, you work in JIPMER, which is, very highly regarded, ethically sound institute, just like PGI Chandigarh, who has started doing DCD. We actually look forward, we all rest of us work in private hospital, all four of us work in private hospital. I think the lead needs to really come up from institutes like JIPMER, CMC Vellore, AIMS, PGI Chandigarh, Niemans. These are the institutes who, if you start doing it, I think there would be if I would say that you would actually lead the path for us, it would be easier for rest of the country to follow. You could sort of pave the foundations for it. You could pave the processes for it, and then there would be absolutely no doubt in people's minds. So it probably needs to come from institutes like you. So what are your thoughts on this? And is JIPMER thinking on those lines right now? Especially that you head the neuro intensive care unit as well as the division. What are your thoughts on that?
Yeah, thank you, Doctor, for that, Dr. Rahul, for that question. Actually, as far as we are there, we are not at all doing that now. As of now, we are considering it, but there are several hurdles to it. Having said that, it's a very good idea, but to implement it, it is going to be a Herculean task. But to be highly motivated to do that. Actually, the main what we can, as of now, we can concentrate on that the patient, like the patients are done the first set of tests or waiting for a brain death declaration and a circulatory death happens. Or we have done a second test of SET and we are diagnosed or declared brain death, and then the circulatory arrest happens. These are the group of patients specifically we should target, because we already have the baseline values. We have already done some amount of investigations, and we have sent the samples for cross matching and all those things. So definitely we should not let the organs go, and can be done because they are under the controlled environment. As far as the emergency medicine department, the patient coming and having a circulated death instantly or in a short span of time, young patient, we should be on the lenient side to consider them. And as far as the older patients, I don't know, because if the history is not available, it's not very difficult. As long as the ICU setups are concerned, most of the patients are die because of the multi-organ dysfunction and all. In the end, it is going to be maybe our last area of choice. Once we get streamlined these areas, we can do it. Definitely, that is the future. We are going to look into it. But as of now, as of I am aware of it, most of the government institutes are not aiming for these type of patients, mainly because of the cost factors. We are putting so much cost into it in the investigations and the surgeries, and they are done at the very levied cost, like 1 or 2 lakhs. Then we want to the best outcome, because when we say that we are going to harvest these organs after circulated earth, definitely the results are not going to be same like a brain dead organ donor who is well maintained in the intensive care unit, or maybe a live donor. So definitely we have to accept some amount of failures, and whether it is acceptable when you're doing it at a reasonable cost, that is the question which is going to haunt us. And as you suggested to us, we are going to look into this matter.
So, Professor Bidkar, yes, Mani sir, just 1 minute. I'll
No, I
speak
just
and
want to
I'll.
come back on that. You see, the quality of organ retrieval after DCD, in the world literature says that 31% have delayed organ function, but eventual outcome is the same. So you will have a subset of patients who are suitable. I mean, of course, suitability we have to see, and then we should also have those system technology to improve the organ viability. They're there now. Hypothermic or normothermic, and then ex vivo perfusion techniques. Okay, in vivo perfusion technique. So if we put all the new technologies in place as well, then you can have organ retrieval and organ quality matching that of DBD. In fact, long-term outcome is no different.
Yeah, that's right. So if you have a 30 minutes of warm ischemia time for a liver, 1 hour warm ischemia time for a kidney, I think the outcomes are absolutely same. So systolic
Exactly.
blood pressure is what they take it as a cutoff. So I mean, let's not get into the intricacies. So I've actually been I just realized that I've got 3 presidents of Indian Society of Critical Care Medicine on the panel right now. 3 of them are there, and as a society, as a IICCM member, as an intensivist, I look up to the society to support me. So I'm going to ask my immediate past president, who is still on the EC member, he's still the EC member, Dr. Deepak Govil. What has the society done to actually support? So we published this paper under the society's banner, no doubt about that. So don't get me wrong. But actually, as a grassroots worker, if I have to do something like this today in my ICU, I have access to Deepak Govil, I have access to Kapil Zirpe, the phone numbers are there on my mobile. I can pick up and speak with Dr. Mani. But what about a junior doctor who is just become IDCCM, who is practicing in a small town, and he wants to have some information about this? How do we get across to our 10,000 plus members, Dr. Govil? And how do we make it easily accessible to them, be it brain dead, be it DCD?
So very valid question, Dr. Pandit, and very pertinent also, and it's a right time to ponder these questions. The problem is that per se society, we have not done too much about this. Although Dr. Mani and conducted a workshop in the conference which we had last 2 months back on April, month of April, 1.5 months back, we conducted a workshop, and last year around 7 of the webinars were conducted with the Transplantation Society in the collaboration with having the panelists from all over the India to just improve the awareness and the knowledge about the DCD in our fraternity. So those webinars were targeted to the critical care specialist mainly, not to the general public, just to increase the awareness. That's it. I am really sorry we have not moved very too far in as a per se as a society.
I didn't mean to cut a sorry face for you at all. I'm sorry
No,
if
no,
I
no,
sort of
no,
got that on the
no.
wrong way.
No,
Wasn't
it's
the
not
meaning of
wrong
that.
way. It's one aspect we couldn't move fast or couldn't take lead. I would rephrase the words.
So, Kapil, as a society, what would you want the future IICCM to sort of, or the current IICCM to actually support, whether it is WLST, whether it is brain death or DCD? Are your thoughts on that? How can actually IICCM support the foundation? Can we lay the protocols? Of course, the government protocols are the sacrosanct protocols. We sort of inculcate them into a more practical protocol, like we did for how do we donate, how do we declare a patient brain dead, and then have some sort of a validation for it. So, your thoughts on it?
Yeah, Rahul, Deepak probably forget what he does during his presidency. He is the first president of the ICCM who has started the joint organ donation webinars with the TCS, ACCS, and but Deepak, when I was talking, there is a mail I received it from the ISCM. There is a controversy in DCD webinar arranged on the 18th of May.
18th, yeah,
Look at the
18th.
society is one step ahead of us. On behalf of the Deepak, let me say that the society is one step ahead of us. Already they declared the webinar. Second thing, society, see, this is something social responsibility of the society. This is not the only academic responsibility. And we need to have certain social wings, like we have various working committee. We can have one of the working committee who is working on only social aspects of the disease, like stroke awareness, like organ donation awareness, like sepsis awareness. There are so many things we can do through that activity. So that one can do as a society. Second thing, what is lacking? What you highlighted a very important point is that the knowledge is lacking. Suppose there is a doctor who is enthusiastic, he is interested, he want to maintain the donor, but he don't have that knowledge. He don't have that knowledge of the apnea test, what problems get there. So he need the help. So ICCM can allot, might be the city branch level. These are the two names which are available for queries related to the organ donation. We have 84 city branches. It's easily possible to request the city branch chairman and secretary to give the number who are ready to willing to share their numbers with the that particular 100 kilometer or 200 kilometer area. They can cater and 24 hours available. That's the thing. Third thing, ISCM can offer help in terms of the I can say the various technologies like ECMO and all these things. Those workshops they can regularly conduct in those areas where it is necessity to aware how to maintain. We are talking about the DCD. So when we are talking about the DCD, the ECMO and hypothermia and everything will come into the picture. So if there is a will, definitely happening, and I am sure ICCM has a good leadership. They are looking into, like Deepak had did. In fact, when I was a president, I hardly did anything except that movie I come up with the organ donation, but that was the social aspect again. So every year we need to follow up of the ICCM leaders to contribute on their behalf. But we can do a lot on behalf of the, though we are educational and training doctors is our primary aim, but social aspect we need not to be forget. That's what I will say.
And Dr. Zirpe, I would like to add one more thing, that DCD is the area which need to be expanded like anything, because in DCD there is no legal hassle as well. It is so simple and easy, and families already accepted the cardiac death.
No, Deepak, huge controversy. Dr. Mani is there, huge controversy. In fact, DCD has a more legal aspect in India. We are in
Yes.
India.
Because you
Let
have
me
to do
share-
WLST.
Yeah.
WLST
Dr.
is
Mani, I will come back.
actually
Dr. Mani, I will tell.
Yeah.
Let me share one experience. Few months back, I had a doctor family. I had a stroke patient. Family themselves come to me that they want to go for the DCD. I had a consent. I had a good relations with the family. I had a patient who was this thing. Everything was willing on paper, but finally, my administrator say that what cause of death is you are going to give and when you are going to issue the cause of death. Because in brain dead patient, you give it after the second apnea test about this DCD. So we went to the government authorities also. There was, sorry to say, but there was no positive response. Everybody says that this is not our area of concern. This is where we are not going to, and we have to finally. Patient was ideal selected patient. Patient was well maintained. Family themselves approached me. We were having the concept of the DCD. We have the all facilities at my hospital, including the ECMO. My teams were willing. but we are not able to do it. And Dr. Mani, let me tell you, see, I don't know, every time you guide us, but when it comes to the ground reality, let me tell you, sir, it is a next to impossible job, this thing. So I know ISCCM in
You see,
2005 come up with
Kapil,
the guidelines, 2012, 2015 about the end of life. But now
yes,
we have to put down and get those
yeah.
things done in a Supreme Court. Yes, sir.
Kapil, if we
Yes,
say
sir.
impossible, then it is, then we are not doing anything. Okay.
Okay, I will
You
withdraw
firstly
the
say
word.
it is possible. Now,
Dr.
see,
Bidkar,
the
I'm going to come back to
difficulty-
you after this.
Yeah.
So,
the
Dr. Mani, you
difficulty-
finish, then Dr. Bidkar.
Yeah. See, the difficulty in the law is that in TOA they don't recommend, they don't prescribe any system, any SOP, any procedure, any forms for DCD. Okay. And the government, although constitutionally valid withdrawal withholding, we do not have a system in place, okay, to conduct, if what do you call, for the doctors to be assured that they will be not be culpable in any way. We don't have a system like that. But I must say, the ISCCM has taken a huge lead. Now, even in this preparation of this DCD paper, consensus paper, you have a table, all the steps that, towards the progression of DCD in India, they are all written, and ISCCM figures very prominently. Because without a system in place for end of life decisions, you cannot have any DCD. So the first paper came out in 2005, and ISCCM was part of this common cause judgment. We implemented, ISCCM implemented, which brought us this right to advance will and a constitutional validity of withdrawal and withholding. What has happened is, what ISCCM must do, it has made these papers, wonderful papers, everything. We have got all the thought process in it, but we haven't done much on the ground.
Yeah,
Why I say that is, we need a workshop, lots of workshops to reach. As Kapil says, you've got to penetrate, okay, into the grassroots. That we have not done. We have kept an intellectual exercise unexpressed on the ground. So we have to go talk to from the junior most intensivist upwards rather than top down. We talk to them and say how it is feasible. If something becomes a practice, like the sepsis thing, everybody knows, even in the periphery, you got to give a fluid bolus. That was not so before the year 2002. Okay, so we must know that there is a possibility of doing withdrawal withholding. There is a process published by the ISCCM. Majority of the ISCCM members don't know there is a guideline. This
Correct,
is a
sir.
pity.
Absolutely.
So if we
Absolutely
do
correct.
that, next step is to really go and disseminate this understanding and make it a practice, bedside practice. We can start with simple things like DNR. And one day we will get confidence in doing WLST. Then you have cracked the code for DCD.
Sir, legal
Dr.
support we are
Bidkar,
talking about.
Kapil, Dr. Bidkar has been raising his hand for some time. Dr. Bidkar, your thoughts?
No, exactly. I was making a point what Dr. Mani sir was doing. So as far as the brain death is concerned, it is brainstem death in India. So it is better to switch over to neurologic criteria for death, actually. So we have to start calling it as a death, because even after 50 years of Harvard criteria, we are not able to convince people that it is a death. So we need to move, as far as the brain death is concerned, we need to move into that direction to make the social awareness. As far as the DCD is concerned, I think, as he rightly pointed out, from the grassroots level, I would say from MBBSC, there is now a National Medical Commission which has got an integrated teaching from first year onwards. So we need to start talking about all these things more frequently to them, add into the curriculum of MD Internal Medicine, MD Anesthesia. We have now DM, DNB in intensive care, fellowships in intensive care, and DM in emergency medicine, trauma, MD emergency medicine, DM emergency medicine, DM trauma and emergency medicine. So we need to put all this into the curriculum of it so that it is more often discussed and the people are more aware. Then the chances of we getting there are much higher. That's what I feel.
Sorry, Kapil, I cut you off. Your thoughts, and then I want all of you to give one minute of last parting thoughts of on this program, because we are already 1 hour plus into the whole process.
Actually, I want to echo the Manish sir. The DCD is the future. DCD is the future for getting over our issue regarding the widened gap in between the demand and the supply. For that, we need to have a supportive legal system. Like Kerala is first state which have accepted the brain death as a cause of death. We need to have every state should be that. So we'll gain that confidence amongst our relatives and the patient. First thing. Second thing, what he said is right. Every monthly we need to have a like webinars like this or workshops at the every part. At least go ahead with the 84 branches of the Pune this ICCM this thing. So that need to be done. And third thing, just follow our legal battle with that much interest. Like it's last 15-20 years we are in a court, but nothing is coming out of this thing. I think that's the thing, except the advance will in 2018 March and this thing. So we are very close to the victory. We are very close to our aim. Let's again fight for that with a proper collective efforts. And the DCD is the future. I mean to say that every country outside India or in the globe is moving towards the DCD, and I think it's possible in India. Sir, I withdraw my word. It is impossible. I said it's possible in India. Thank you.
Thanks, Kapil. So parting words with Kapil. It's possible. We should do it. Dr. Govil, Dr. Bidkar, Dr. Mani, in that order. One minute for you all to just give some parting message.
So I agree with Dr. Mani and Dr. Kapil that DCD is the need of time, and it is the future of donation, and it is already established as a future of organ donation and the retrieval program in many of the Western world. And I agree that we should have more workshops like this. I'm observing one workshop done by this TTS, the Transplantation Society, and it's amazing. So we can replicate that type of workshop in India very well. And it's not a big deal. It's simply just a discussion and giving a scenario. So we can plan such type of activity in future. Thank you very much.
Dr. Bidkar?
Yeah, this brain death, DCD and organ donation has a lot of issues like medical, social and ethical. We need to look into all three issues simultaneously and try to sort out them. Particularly, we need more of a legal help and a clarity from the administration what we are going to do. The expansion of the include the people like anesthetist and intensivist for the part of the declaration team is a welcome step from the government part of it. We need to also educate people. Maybe we can create through the ISCCM or the other societies like the toolkit what a neurocritical care society has done for the declaration of the brain death. Maybe we can have a scenario in India and a certification course also like we have FCCS and others. Maybe a one-day certification course also may help the young budding intensivists. Like we have the through the society fellowship courses. So we can make that they will mandatorily attend these courses so that wherever they go, obviously they will go to move into B towns and C towns where the knowledge will spread. What do you?
I completely agree. So we need to involve that into the teaching for students. Dr. Mani, your words.
You see, I want to say that it's now very clear that intensive care training must include training in skills required for organ donation. The skills will include communication, which we need to focus on and actually train in a structured manner. Number 2, skills in maintaining the potential organ donor. And number 3, skills in end-of-life care, end-of-life decision-making in limiting life support. So, because this will open the doors for expansion or into the advances of medicine via critical care. It will also intersect with socially, collectively very important issues, which intensivists, started to taste this in the COVID times. We came into prominence, we came into limelight because we intersected with social needs, directly. We are always with social need. But what I'm saying is entered as advocates, as activists on behalf of society. So we must not shirk our responsibility. As Kapil said, it is possible, right? So we must say it is possible because it's socially important. It's important that we are in step with the times of the world. Okay, times are for intensivists. Future is now.
So we should not shrug our responsibility. Definitely, it is possible. Involve that into a part of a curriculum for our students. And as Dr. Deepak said and Kapil said, that we need to get to the ground level intensivists by organizing more and more courses for them and having a simplified version of the courses, not too complex. Maybe even go down to the vernacular language for some of them to actually be able to role play it well, because that's one of the things which I see when I speak in Marathi in Mumbai or Hindi in Mumbai. It's completely different for the family to understand when I'm actually talking in English. So I think that local language connect is extremely important. I'm sure Dr. Bidkar, Tamil would be a very important skill to be possessing if you are going to work in Tamil Nadu. Without that, you will not be able to convert any of them. Thank you very much. Dr. Jagasi says it is important to convert this into a curriculum and discuss this more often. We've had some more doctors talk about that interesting subject. Somebody is Vaishali saying spiritual connection. I think all of these are questions, but the intention of this webinar was not to get into these controversies about spiritualism, religion, or misconceptions. It was just basically simply discuss the plain simple medical facts, and I think we've come out with that quite nicely. Thank you. I thank each one of you to bring out and put it out so simple, in such a simple way that the intensivist or the common people or the anesthetists who are sort of listening to this program actually have understood the nuances of what we are talking about. So I thank Professor Mani, Professor Govil, Professor Zirpe, and Professor Bidkar for sparing their time on a Saturday evening away from their family. It's been more than an hour we have been discussing this, and I really hope that this sort of webinar paves way for many more to come, and we have a simplified and a protocolized version of a webinar, so that even in an hour's time we are able to cover up the main important aspects of a DCD process or a brain death process, which will be carried by the junior intensivists, junior consultants, doctors moving forward. Thank you very much. Thank you very much.
you.
And I
Okay,
thank
thank you.
Aniruddha, thank you very much for your support as always. I really appreciate all of that. Thank you.
Thank you.
Okay.